Clinheim, Hematology, Demystified.
Okay, so I hope everybody can hear me and the slides are moving. If they are not, just let me know. I'll assume they are. So today is week 2, and we are going to cover some important causes for anemias. Of course, not everything about anemias is going to be covered, and I will explain what we are going to do in a bit. So uh, a seventh week, of course, for this block would be the practice/mock session, which will be quite heavy, and we will cover everything that we have covered in these 6 weeks. So before we go into what we're going to cover, just a brief refresher about what you already know. So hematopoiesis, so we have a pluripotent, this is quite a simplified version of it, by the way. We have a pluripotent stem cell that differentiates into myeloid stem cell and lymphoid stem cell. And what we are going to focus on today is that the myeloid stem cell is supposed to give rise to a pro-erythroblast or erythroid precursors, which ultimately become red cells. Of course, there are lots more cells in this differentiation pathway than what are shown here. And the problems that we are going to discuss today are going to be to do with this line, either directly because of problems here in the stem cells or because of other problems interfering with the stem cells. So this is a busy slide, but I just want, of course, you don't need to memorize this, but I just wanted to put this out there so that people have like a mind map of, whatever we are discussing as a cause for anemia, where it fits into the overall anemia pathway or tree. And of course, there are clinically more commonly used pathways like that. That would differentiate them based on the MCV, which we will cover one day. But this is just like to keep an idea so that you know where things fit in. So anemia can be absolute or relative. Of course, relative anemia is not true anemia. Absolute is can be from easy causes like blood loss and redistribution, for example, in the spleen, or it can be from decreased production or increased destruction. Increased destruction can be acquired or hereditary. Everything can be acquired or hereditary, but in increased destruction acquired, of course, we did a very lengthy session on immune hemolysis last time, so that's one of the most important causes. And there are non-immune causes for hemolysis as well, as you know, which include MAHA, infections, etc. Um, in the hereditary causes, red cells only have three things: so membranes, some enzymes in the cytoplasm, and hemoglobin. So problem with any one of them can cause hemolysis, and these are, of course, as you know, acquired. And then coming to decreased production, it can basically be from one or two things. So intrinsic stem cell failure, so problem with the stem cell number or function itself, and or it could be a functional impairment of the stem cells from other problems. So in the first subsection, this there could be an intrinsic problem with the pluripotent stem cell. It's the pluripotent stem cell that I showed you in the top. Of course, that will likely give you more than just anemia. So will give you multilinear cytopenias, etc. So acquired causes like acquired autoimmune aplastic anemia. Of course, it's a misnomer. It's not just anemia. There is neutropenia. There is thrombocytopenia in there as well. MDS and other or bone marrow infiltration. Things like sorry, somebody asking a question or just not on mute. Let me have a look. Okay, so sorry. So yeah, so pluripotent stem cell failure can be acquired or inherited. So acquired causes include low number of stem cells like aplastic anemia, which is the acquired version, or other problems as you very well know, MDS and AML and etc. Inherited causes of bone marrow failure syndrome can also cause a similar problem, and this is going to be discussed in a separate session. And then problem specifically with the erythroid progenitor stem cells, progenitor stem cells. And again, they can be acquired or inherited. Acquired, of course, as you know, Pyruvate cell aplasia. And in here, of course, you will expect mainly just anemia, single lineage problem, because it's just the erythroid precursors that are selectively being affected. The acquired, for example, acquired Pyruvate cell aplasia, and inherited causes like Diamond-Blackfan anemia, congenital dyserythropoeitic anemia, and hereditary sideroblastic anemia. Then coming to the functional impairment of the stem cells, it again can be acquired or inherited, acquired from very well-known nutritional problems or anemia of chronic renal disease. Inherited, similarly, there are problems in the metabolic pathways for the nutrients like B12 and iron, which can cause anemia as well. So this is like an overall plan, and what this will be the layout today. So we will start with the very important nutritional causes, then we'll jump on to some of the hereditary causes, which are hemolytic and erythroid progenitor failures. Because of course, if we were to discuss all of them today, we'll be sat here till spring 2026. So what we're going to focus on is this bit, the functional impairment acquired and inherited bit, and in the hereditary, we are going to discuss these two. We've discussed immune hemolysis previously. We will discuss the remaining in each of the sections. So there are weeks for haemoglobinopathies, and then there is also a week for aplastic anemia and bone marrow failure syndromes. Okay, so I hope there are no questions up till here. So we'll jump, nothing in the chat either. So we'll jump straight to iron deficiency, which is very, very common. As you know, it's actually the most common cause of anemia worldwide and a public health concern because of its very significant, far-reaching consequences. I've just highlighted a few of them here. It can actually signify an important underlying illnesses, as you all would know. For example, cancer, and that's especially in um, people who are postmenopausal females and in males of any age. Because males of any age are not supposed to have any blood loss. Iron deficiency means blood loss until proven otherwise. And this can be from a cancerous problem in the gut, of course, as you know, or genitourinary system. Um, and just as a reference, iron deficiency anemia is actually present in 30 to 60% of patients with colorectal cancer at diagnosis. So 60 up to 60% of patients who have colorectal cancer, if you were to follow them up retrospectively, then you will see that they were actually iron deficient at diagnosis. So that's why it's so important, and that's why you never see that gastroenterologist would reject your referral for iron deficiency anemia to consider upper and lower GI endoscopies. In younger patients, basically females, you can see iron deficiency anemia very commonly, and most commonly this is just from menstrual blood loss that has not been replaced adequately. But sometimes it can actually suggest that there are inherited bleeding conditions, disorders present in young patients. But of course, not everybody, because by far the more important cause is just menstrual blood loss. But if you see person getting iron deficient and again, a young female, and then you dig into a bit more bleeding history, then you might find some inherited bleeding disorders like von Willebrand in there, for example. So that's why it's very important. And maybe most importantly for us, it keeps the DTH hematologist quite busy, so it makes up a major portion of what you do on a day-to-day basis as well. So it's very important to diagnose it and treat it accurately. The diagnosis, there are some parameters. Of course, in the full blood count, that's widely available. So you would show low hemoglobin if there is anemia, but there is a thing called iron deficiency without anemia, needless to say. The MCV would be low, MCH, which is a mean corpuscular hemoglobin, would be low, and similarly, mean corpuscular hemoglobin concentration would be low as well. But of course, as you know, all of these things can be present in thalassemia as well. MCV is normal in up to 40% patients in iron deficiency, and normal RBC parameters do not exclude iron deficiency. So, iron deficiency is still important to diagnose because of some of the reasons that I mentioned. Some more before we jump onto the main thing, which is ferritin. Some more parameters from the full blood count itself. They're not new now, but they're a bit less known. So percentage of hypochromic red blood cells. So percentage of those cells which have got a hemoglobin of which we basically call low hemoglobin in the cell itself. So if it's more than 6%, then this reflects iron deficiency or iron restricted. Either reflects iron deficiency itself, or it reflects that the iron is not being utilized to make hemoglobin. Um, but there's a caveat that, of course, it can still be low. So all of these things can be low, can be similarly showing in thalassemia as well. Same for this. But there's a problem that it needs doing in 6 hours. And it doesn't reflect the last 3 months because, as you know, the lifespan of RBC is 120 days. And when you're checking somebody's blood, they have got cells of various ages in there. So you're actually checking the whole entirety of red cells to see how hypochromic they are. It will reflect the last 3 months. So it won't reflect like how the iron status is right now, but it will reflect the last 3 months. It needs doing in the 6 hours because if you take a blood sample, of course, you take it in EDTA, the red cells are going to swell up, and that swelling would artificially cause a little bit of because there's more water coming in the cell, so you can imagine that the hemoglobin concentration is going to drop a bit. And if you leave it long enough, after say after 4 to 6 hours, then it will be quite significant to falsely show that some of the cells are hypochromic, and you will see a falsely raised hypochromic red cell percentage. So that's why you have to do it in 6 hours, and that is a pain to do, especially say if your sample is coming from like a GP surgery to a tertiary lab or something, then sometimes the transit time is quite a problem. The other thing that's been developed is checking the hemoglobin content in the reticulocytes, which are, as you know, the fresh red cells, young red cells. So this is basically the reticulocytes mean corpuscular hemoglobin, and if it's less than 29 picogram, that again suggests iron deficiency or iron restriction. The same problem thalassemia would, of course, because of low hemoglobin, they will have that as well. This can be done, up to 12 hours after the sample is taken. This actually reflects the last 2 to 3 days of how the things have been going because of obvious reason that you're just checking reticulocytes. And of course, the most important thing is blood cell morphology. In iron deficiency, you start with anisocytosis, which is different shapes, different sizes of the red cells, and then progressively they become hypochromic and microcytic. It's important to rule out other pathologies, but characteristic findings for iron deficiency are things like pencil cells. They are present. They're usually present when not present until the hemoglobin drops below 100. So you cannot use it exclusively to rule out iron deficiency. So in summary, RBC parameters, the usual ones, can suggest that film morphology is going to help you rule out other problems. But some of the more specific, so to say, things that you can use is hypochromic red cell percentage and reticulocyte mean. The way to remember the 6% and 6 hours is that HRC and RBCs, this is how it's stuck in my mind. So there are 6 letters, so 6 is the number that you need to know. And for reticulocyte, it would have been nice to have like a 30 or something, which is makes sense, but they're quite mean, so they wanted to make it 29. So that's how I remember it as well. So 29 for retics and 6 for red cells. And 30 is the same number for ferritin that we will discuss, which is one of the magic numbers as well. Okay. And then coming to ferritin, which is the most important test, as you know. So in a steady state, if a ferritin is low, that is iron deficiency anemia, nothing else. And the guidelines will give you a cutoff. In the UK, this is what we use. So less than 15 in more than 5 years of age, or less than 12 micrograms per liter in under 5. But again, the problem of so many tests to diagnose the same thing, because each test will have its caveats. So of course, ferritin is an acute phase protein. So in acute and chronic inflammatory states, it will rise up, and then so normal ferritin does not exclude normal or raised ferritin does not exclude iron deficiency. Transferrin saturation is a good marker. So if it's less than 16%, our guidelines suggest that this suggests low iron, but some international guidelines do consider even less than 20% to be consistent with iron deficiency or iron restricted hematopoiesis. Now, it is how do you find it out? It's basically serum iron levels divided by transferrin, which is the transport protein that transports iron in the blood. Or there's another variable, total iron binding capacity is basically a measure of how much ferritin, transferrin there is. So you either use transferrin or TIBC, but this is how you do it. So serum iron divided by transferrin or TIBC. And then if this is 16% or less, this suggests iron deficiency. But problem is that transferrin, so ferritin rises in acute inflammation. Transferrin is a negative inflammatory marker. So transferrin drops in inflammatory states. So again, in inflammation, you can see there's a problem. Ferritin is going to go up, transferrin is going to go down. So our iron markers are not, are going to be affected. So transferrin saturation, normal transferrin values or transferrin saturation, sometimes, you have to take it with a pinch of salt, still, if there is quite significant inflammation going on. A lot of people do serum iron because it technically makes sense, maybe, serum irons are low, is iron deficiency, but serum iron on its own is useless, and this is a common MCQ and actually a real life question as well. If you there's law of diurnal variation, number one, but if you take like a heavy meal with iron or iron supplements or meat or whatever, and you check your iron levels, it would be high. So yes, it's useless on its own. The only use of doing serum iron is to calculate transferrin saturation, which is better. Okay. There are some other markers which are not recommended. The soluble transferrin receptor is quite a difficult test to do, but it's not recommended anyway because it doesn't add a lot more than what ferritin would do. And it's not useful in early disease. So yeah, even it's late disease, and other markers will hopefully show it as well. Zinc protoporphyrin is increase in iron deficiency, but again, not suggested because it's increase in lots of other causes. For example, high bilirubin, CKD, any anemia of any cause, and thalassemia, etc. Now, zinc protoporphyrin. So if there's iron deficiency, the thing is that in the final heme pathway or whatever, the body will, because there's iron deficiency, the body will try to incorporate zinc in its place. And then as a byproduct, ZPP will be elevated in iron deficiency, but we don't use it. Hepcidin is a good marker, but it's not currently recommended because the testing is not widespread, but there's an ELISA test being developed, which will hopefully, if it becomes widespread, then hepcidin will come into use. Now, in iron deficiency, it will be low, and I'll explain what hepcidin is and how it works in a second. So as you can see, iron deficiency is very important to diagnose, but there's not one test that's absolutely perfect. If ferritin is low, that definitely means iron deficiency. But if ferritin is high, you need to, in terms of acute or chronic inflammation, then you need to see other tests like transferrin saturation or reticulocyte mean hemoglobin content, and then make like a comprehensive diagnosis. Any questions up till iron deficiency diagnosis? No. Okay, so iron deficiency anemia. Yeah, so this was actually what I was supposed to say. So in summary, you see if there is inflammation or not. If there is no inflammatory state, um, then you check what the ferritin is. Ferritin, and if it is low and guidelines suggest 15, then it suggests iron deficiency anemia. Otherwise, if it's raised in the absence of inflammation, look for other causes. There are some other international guidelines that suggest higher thresholds, and also the guideline will suggest follow your local lab thing as well. But for exam, of course, you're supposed to stick with the BSH guideline. If there is inflammation as suggested by the history or by a high CRP, then if the ferritin is, you still do the ferritin first, of course, because it can still be low sometimes. So why complicate things? So ferritin, if it's less than 15, then it's again IDA or iron deficiency at least. If the ferritin is raised and the guideline gives you an upper limit of more than 150, if it's raised and it's more than 150, then it's unlikely to be iron deficiency, they say. Rule out other causes. But in reality, what happens is that you can't rely on just like a one cutoff for ferritin, because the loss of stage that can give you a massive rise in ferritin, but the person can still be iron deficient. So if you really do want to check, and the ferritin is below is between 15 to 150 is what the guideline says, or even if it's above 150, you would still want to, side by side, of course, you will do other tests. And the guideline suggests that of course, we see film to see how what are the causes, and find the evidence for iron deficiency. Or guidelines suggest TG-SATs less than 16%, or reticulocyte, mean reticulocyte hemoglobin content, yeah. And then that is, if it's less than 29 picogram, that suggests iron deficiency. This is what the general approach is suggested in for iron deficiency diagnosis. Okay, that's good. And then coming on to pregnancy. So a few slides about pregnancy. It's very important to diagnose it in pregnancy for lots of reasons I've already mentioned. Of course, iron deficiency in itself is quite bothersome for quality of life for many people, tiredness and headaches and weakness, etc. But in pregnancy specifically, it can increase maternal morbidity and mortality. And for the fetus and the baby as well, it's not good. So it can increase their morbidity and mortality, but also affects neurodevelopment later down in the life as well. So again, very important to correct and treat. All the testing falls apart in pregnancy because of various reasons. So guidelines suggest if the ferritin is less than 30, that's fine. That's iron deficiency, you treat it. But if higher levels do not exclude, and you try to get some idea from history and blood film and other things, but nothing is specific or sensitive for pregnancy itself, you just have to make a clinical call. Other option is just to try a trial of bio iron, and HB should rise in 2 weeks if this is just purely iron deficiency. Of course, you in the UK, you would know if a person is a carrier for thalassemia or something like that to cause when they're pregnant, to be causing the microcytosis, etc. For them, you check a ferritin first, but otherwise, you don't even need to check a ferritin if you suspect there's a hypochromic microcytic anemia without, thalassemia trait or anything like that. You can try a trial of iron and see if the HB rises in 2 weeks. But of course, if they are in later down in the pregnancy, and you want a quick rise, then you can consider IV iron instead of oral iron, because IV is going to work quicker. And I'll explain some of the contraindications for that in a second, which is actually here. So how do you manage it? First of all, you confirm the diagnosis with all the caveats that I mentioned. You identify the cause, because it almost always means bleeding from somewhere. Very rarely, it's like a diet problem. Then you correct or manage the primary cause, but otherwise it's not going to correct, because it's like trying to, because a tap is open and you're trying to replace water, you need to close the tap and provide iron therapy, which can be done orally, which is first line, or parenterally. Orally, what you're supposed to say is, less is more. So one tablet once a day in the morning on an empty stomach with a bit of orange juice if they're allowed. That is, they're not diabetic or anything, or otherwise water. Avoiding tea or coffee 2 hours before or after, or any other multivitamins and PPI, etc. 2 hours before and after. So this is for the best results, and you see quite good improvement. If they're struggling with symptoms like tummy discomfort and things like that, then you can drop it down to one every other day. And the tablets should have, the usual tablets, ferrous sulfate, fumarate, etc., should have like 80 milligrams of elemental, 60 to 80 milligrams of elemental iron. So any of them are okay. Over the counter ones are not good, because they contain not only iron in them, but they also contain other multivitamins, which are going to inhibit the absorption of iron in the gut. And the iron is just going to stay in the gut and cause abdominal cramps and constipation, and not going to be absorbed. The rationale for previously we used to use, if you remember, twice a day or thrice a day or whatever, but recent studies have, not recent now, but studies have shown that if you take iron in the morning, for example, your hepcidin levels as a reflex go up, and the afternoon and evening doses are not going to be absorbed very well. They're going to stay in the stomach, in the gut, and just cause problems. So that's why once in the morning on an empty stomach is better rather than twice a day or thrice a day. If that's still causing problems, even after changing to a different preparation or changing to alternate days, etc., they're having significant problems like constipation or abdominal cramps or not tolerating, then you can give parenterally, which is IV iron. And indications that we supposed to know are when other than PO being ineffective or not tolerated, is when rapid correction is required, of course, perioperatively, the surgeries in a few weeks down the line, patients anemic from iron deficiency, you don't give them transfusion, you you actually give them IV iron. Or in pregnancy, if it's late pregnancy after first trimester. Now, anybody knows any contraindications to IV iron? Anybody wants to type or shout or
I think history of hypersensitivity in the past is a
yeah,
contraindication.
yeah, very good. I can think of one, two. Yeah, I can. Yeah,
Decompensated liver disease.
sorry.
Decompensated liver disease.
Yes, very good. Yes, that's something that's not well known. Yeah, that's second. I can think of one more.
I think
Please.
there are, if a patient is having an active ongoing infection,
Yes, very good.
especially
Yeah,
with Yersinia,
yeah,
they
yeah.
are iron
Very good.
deficient.
Yeah, yeah. So we say avoid in quote unquote raging sepsis, but once the infection settles, you can consider this is not like a very highly enforced thing, but this is the good practice to do so. Yeah. So we've said hypersensitivity reactions, but then you can try the other formulation. So one formulation causes a problem, you could try other one. But yeah, that's one contraindication. Non Decompensated liver disease is the other. Number three is active raging sepsis. And last, number four, one more. It's in the slide as well.
I think they don't give it in first trimester.
Yeah, it's not licensed for that, just because it's not been studied and safe stuff. Yeah, that's all. So you might think these are day-to-day things and stuff, but these are important exam questions. And not very long ago, these were the talk of the town for even part two vivas and stuff like that, which was is a good thing to have because it's an easy one thing that we do all the time. And lastly, you have to confirm the therapy success, which is hemoglobin should normalize, iron levels should, ferritin should improve, or if that was low in the beginning to begin with. But if in case of failure of response, there can be lots of different things. Of course, underlying cause is not being addressed, so that needs to be addressed. If you can't find anything, or if the person is having repeated, iron deficiency anemias from microbleeds or etc., then you have in the gut, for example, melena or epistaxis and things like that. You definitely need to consider and rule out HST, and I'll show you the diagnostic algorithm in the next slide, and that's an important MCQ question that they ask. Uh, Compliance. There could be mixed deficiency. If you're using PO with the right method that I've mentioned, then still malabsorption can be a problem. Or it could just be the wrong diagnosis, all the things that I mentioned. There were so many caveats. So it could be wrong diagnosis, it could be thalassemia, TATO, whatever, or it could be something called iron-resistant iron deficiency anemia, which I will discuss in a second. It's an inherited condition, very rare. So this is the HST diagnostic criteria. So you, four features: spontaneous recurrent epistaxis, mucocutaneous telangiectasias, a visceral arteriovenous malformations, and first degree relatives with hit. So if they are all four, then this is a definite. Three or four, then this is definitive for HST. Otherwise, it's as stated. Of course, there are genetics that you can do as well. Because these patients, there are some treatments now that you can give them to reduce their telangiectasias, etc. But it's important to diagnose because, of course, clearly there are other long-term consequences for them, and iron deficiency again being one of those things that helps you direct to a more serious quote-unquote diagnosis. Okay. Okay, so that was about iron deficiency. Now, briefly about hepcidin. So there's something in the chat actually. Yeah, somebody said first trimester, that was for iron. Fine. Good. Hepcidin, as you all know, is the only way body regulates iron. So the only regulation point for iron is at the absorption stage. There's no pathway to actively excrete iron from the body. Now, we know for the ferric form how it's absorbed, but for heme iron, we really don't know a lot about. But anyhow, for this, the ferric iron in the gut goes into the small intestine cell. This is the luminal border, this is the basal border, and goes in it might be stored as ferritin here if the body's got no need. Otherwise, it will be, when it goes, it will be, you don't need to know all of this, that if ferric and then goes to ferrous. And then, but what you need to know is this thing called ferroportin, which is the transporter, which is going to transport it out into the blood, again back as ferric, where it is coupled with transferrin and goes into the bone marrow macrophages, which are going to help provide the erythroid cells with iron to make more hemoglobin. But this is the regulation point, which is a ferroportin, which is a channel, and this is regulated by hepcidin. Hepcidin is going to stop this from doing its job, so it's going to cause phagocytosis and degradation of that. Not phagocytosis, internalization and degradation of this thing in the cell. You'll have less ferroportin to do its job. So hepcidin is going to basically block this pathway, and then iron is going to stay here, and it's going to be shedded off when the intestinal cells are shedded off in the stools. It's not going to be absorbed. So what increases hepcidin decreases iron absorption. So iron overload increases hepcidin, and inflammation increases hepcidin levels. Of course, anemia and hypoxia are going to, downregulate hepcidin. Now there is a inherited problem, which is IRIDA that I mentioned, iron resistant iron deficiency anemia. So the problem is that the problem is here, hepcidin and ferroportin. But basically, they're going to have a upregulated hepcidin form of mutation, and that's going to keep it constantly blocked. So even though there is lots of iron coming in, it's never going to be used from this pathway. So it's the oral pathway that's blocked. The person would be iron deficient, and you can bypass that by just giving them IV iron instead by higher doses, usually. Coming to functional iron deficiency, because you mentioned hepcidin, insufficient iron incorporation into the erythroid precursors despite adequate body stores. So that's how of course, this is what it means. There are two main, of course, it can be acquired or inherited. Acquired, there are two main mechanisms, which is, you all heard of this: acquired anemia of chronic disease from infection, inflammation, malignancy, etc. Or in CKD that's treated with EPO, there's also like a functional iron deficiency element there as well. Now, how you diagnose it is same that I mentioned. So percentage hypochromic red cells, HRC, RBC of less than, I should say more than 6%. Didn't say less than 6%, more than 6%. And reticulocyte hemoglobin should be the other way around. Let me just, reticulocyte hemoglobin of less than. Yeah.
Sorry, Hassan, I'm interrupting you for this.
No, that's
The
fine.
percentage of hyperchromic red cells which you're written as 6%. I was, because I told you I didn't get time to read the guidelines through and through.
Yeah,
I
yeah.
was trying to read them on way back. I mean, the BSH says it's 5%. I'm not sure. I wasn't here before 10, 15 minutes when you started it. So
I
I'm not
think it
sure.
is.
Was there
I think
something that was discussed?
yeah, I think it is 6%. Maybe they say less than equal to 5%, but definitely in the functional iron deficiency word is 6%, and this is based on the latest nice guideline on CKD and anemia. I will send you a link for that. So there's a nice guideline which is more up to date than the functional iron deficiency VSH guideline that was there. So I've used the more up to date one. I think it was 2024 or something. Okay. Yeah, so reticulocyte hemoglobin. So, and I'll say at the end, we can discuss what the caveats are for hypochromic red cells for yourself if you need. If not available, or because these two things, as I said, will also, of course, be problematic with thalassemia and things, or if they're not available, then you can do TSATs, and the nice guidance suggests that if the TSATs are more than 20%, if I think more than 100, this is not iron deficiency. I've said everything other way around, sorry. So iron deficiency is when so either hypochromic cells more than 6%, reticulocyte hemoglobin less than 29, but if they're not available, T cells less than 20 and ferritin less than 100, and they suggest we use both of them together. BSH guideline says if the ferritin is less than 200, if the person is on hemodialysis, but the NICE one doesn't mention that. NICE just says TSATs plus ferritin of this much. So as you can see, the BSH guideline on iron. So BSH guideline, the good practice paper on iron deficiency is for steady state. So it's not for iron restricted hematopoiesis. There's a different guideline, functional iron deficiency, which is there, I think, in 2014. But these criteria are based on the most up-to-date NICE guideline, which overtakes everything. So that's in 2024. And the reticulocyte hemoglobin, if it's less than 30.6, it's actually a predictive marker that the person would respond to IV iron if you give them. This is all in context of CKD-related anemia. But it suggests keeping ferritin less than 800, because if you keep giving iron, then you can overload them actually. Okay, and with the complication. So as I mentioned, iron refractory IDA, a very easy MCQ. There's a mutation in this gene which controls hepcidin. So if that's a problematic, you have high hepcidin levels with the problems that I mentioned. You can bypass that a bit with higher IV iron doses. Okay, good. So anything about iron, because we've done with iron? No, that's good. So B12 folic acid, there are lots of causes. You can go through the BSH guideline for that, but I will mention briefly some of them. So B12, infections, malabsorption, but what we need to focus on is the pernicious anemia, which is autoimmune disease, and folic acid as well, infections, malabsorption, drugs. But folic acid is usually seen in poor dietary states or excessive alcohol and things like that. Important points to know are that they both will cause pancytopenia, not just anemia, of course. Megaloblastic changes are going to be seen in the bone marrow, not in the peripheral blood, very unlikely to. Peripheral blood would give you macrocytosis, which is different from megaloblastic change. Megaloblastic change means that in the erythroid precursor, there's nuclear to cytoplasmic dyssynchrony. So nucleus is not maturing at the same speed as the cytoplasm. There's a lot of intramedullary hemolysis. So because these are cells that are not stable for their stage of the illness, so for their stage of differentiation, they are going to hemolyze inside the bone marrow, and that is going to give you a massive rise in LDH, and you see LDH is in like 3,000 to 4,000 if your upper limit is like 250. And neurological features are seen in B12, of course, is required for the cells as well, and they can be there with normal MCV. If you correct folic acid, that might that might correct the FPC parameters of megaloblastic anemia. But if they have concurrent B12 deficiency, of course, this wouldn't correct the neuro problems. They're just going to make it worse. The reason to say that is people B12 they link with full blood count, so B12 deficiency should definitely have a full blood count problem. That's wrong, because B12 deficiency can be there with a perfectly normal full blood count, and that is why the neuro problems can be there with a normal full blood count. So if you correct the folic acid, corrects the hematology FPC parameters, heme parameters, then people would think, oh, it can't be B12 deficiency, blah blah, but it can still be. So that's important to remember. And this is a picture that shows, as probably everyone has already seen, hypersegmented neutrophils, macroveilocytes, and not a lot of polychromasia, but there's anemia there. Okay. Now, again, like ferritin, the testing is not great because lots of caveats, and we don't actually know what exactly the level is where it becomes low for B12, but we have just done studies and tried to get a good number. So you heavily rely on clinical features, so full blood count findings, blood film findings, and clinical features of illness, for example, if it's pernicious anemia and things, so glucositis and things like that, or being at risk for deficiency for them. You can either use total B12 or you can use active B12. What the latest guidelines, or you can use MMA or homocysteine. I'll show you a diagram. So this the as you might remember, these are the the molecules or in the pathway of B12 metabolism, etc. So you can use all of either three of them: B12, active B12, MMA, and homocysteine as well. But homocysteine is not mentioned here in the NICE guideline because it's tricky to do, and I'll explain in a second why. But in pregnancy, you should use active B12. That's what the new NICE guideline suggests. If you suspect nitrous oxide related deficiency, so as you know, nitrous oxide is not commonly, I don't know, actually I've not done a research, but it is abused. And then it can give you B12 deficiency, functional B12 deficiency. You can't use either of them. You have to use plasma homocysteine or serum MMA. I'll tell you what happens to them in B12 deficiency in a second. Folic acids, you can just do folic acid levels. There's another test that checks the folate in that cell for that second line. And folic acid will only give you homocysteine levels are up, but MMA levels are normal. Now, this is of course, you will not remember this until spring, but just to mention, this is how it works. So homocysteine goes to methionine, MMA goes to succinyl-CoA. B12 is required for both of these steps. Folate is just required for this step. So of course, in folate deficiency, you will only see a rise in homocysteine. B12 deficiency, you will see a rise in homocysteine and in MMA, because both of them would not be going into their respective products. How do you remember it? B12, B for both, so both of them are going to be up. Folate is for few, so only homocysteine is going to be up. If you forget which one was going to be elevated in both, which is homocysteine, MMA, not everybody can't do MMA. It requires a lot of boxing and fighting and stuff like that. So we are all Homo sapiens. So homocysteine is elevated in both, but MMA only in B12 because B12 has both. Okay. Causes. So you investigate as per the history, malabsorption or whatever. You do a pernicious anemia screen as well, and that's done by intrinsic and this is what is relevant for us, anti-intrinsic factor antibodies. They're specific. If they're positive, then this suggests that this is pernicious anemia, which is basically an autoimmune problem against intrinsic factors. But they're only positive in 50%. So half of the pernicious anemia will be negative for that. So you can't rely just on that. Another caveat is if it is present in very high titers, then you can actually see a normal cobalamin level, total cobalamin level, which is a lab artifact. So imagine this: a patient has pernicious anemia with all of those features, blood film, glossitis, and macrocytic anemia, MCV is more than 110, but B12 levels are normal. It's because the titers can cause a falsely normal cobalamin level sometimes. So that's why you have to do other testing. So you're still suspecting this could be B12 deficiency and folate deficiency or folate deficiency. You have to do other tests, MMA and things to confirm that. Another caveat: there's a version of test which is just done by chemiluminescence, and because this relies on cobalamin binding to see how good it binds to cobalamin or not. If a person has recent cobalamin injection, that's going to give you falsely positive intrinsic factor antibody. So that's again, so you have to think the test should be done before they receive the first dose or something like that. Other antibodies are called anti-gastric pruritic red cell antibodies, and in MCQ they are always going to be no, they are not the right answer because they are not specific or sensitive to diagnose pernicious anemia. So homocysteine and methionine, sorry, I forgot to mention homocysteine. The problem with that is that you have to do it as soon as you take the blood test, and you have to transport it cold, as the sample has to be kept cold to the lab. You might remember, and might give you bad memories from the last session, cold, warm, blah, blah, but this is simpler. So homocysteine, this process is going to be, continued even in the test tube itself. So if you keep the cells in there, then they might give you high homocysteine levels just because the enzymes are still doing their job, and the homocysteine is being produced from mechanisms of the, so that's why you have to do it as soon as possible. Otherwise, if you keep it in the sample, the enzyme is going to continue to work, and body is going to continue the red cells are going to continue to generate homocysteine, and you'll see falsely high levels. And you keep it cold because this process happens at a much higher speed. The process of making homocysteine happens at a much higher speed at room temperature. You keep it cold and you rush it to the lab, which is both of them are extremely difficult. That's why the guidelines, when they say MMA, might be better to do and easier to do. But if for exam, you do both of them, and homocysteine and MMA both are up in B12, and only homocysteine is up in folate. And in reality as well, because if you want to differentiate, you have to take the pain of doing homocysteine. It can be done, but you have to remember, if you see a level, was it done rightly or not? Because you don't want to know that the test was done after 4 days and then homocysteine was so high or whatever, and you diagnosing wrong stuff. You have to know the background of the test. Okay, so this is from NICE guideline, and this gives you, because as I said, we don't have like a exact value where if it goes below that, you magically diagnose it. So they give you cutoffs for that, confirmed, intermediate, or unlikely deficiency. So less than 180 is, BSH guidelines is just using picomoles per liter. So less than 133 is confirmed deficiency, less than 25 for active is confirmed deficiency. Management principles are similar to iron deficiency, to be honest, but you do not delay for results. B12 used parentally for most indications. If you have to use orally, minimum dose that you use is 1 milligram OT. That's what the NICE guidelines suggest. You confirm therapy success with normalization of full blood count parameters if they were abnormal, or the clinical features. Duration depends on the cause, but if you're suspecting pernicious anemia, and you have to remember, right, negative antibodies in 50%, you give it for lifelong because it's a vitamin and it's low risk. So you don't want to risk serious consequences of pancytopenia and the complications just because of not giving it. But if you think this was from a specific problem, malabsorption or something, and you've corrected that, you can consider giving lesser duration. But there are two flowcharts in the BSH guideline which you can go through. But basically what they say is if there's any suspicion of pernicious anemia, you give it for lifelong. Give it lifelong. And if it doesn't confirm, then you go back to your testing again to see if there's other causes, or you make sure if you haven't done MMA and homocysteine, for example, you do them again, or you do active if needed as well, to see if it is actually B12 folate deficiency or not. That's all. B12 folate, iron, blah blah blah. Lastly, we are going to cover the hereditary hemolytic causes, which are membrane, enzyme, and haemoglobinopathies, but we're just going to discuss the top two. Before I do that, hereditary hemolysis usually gives you these clinical features. So of course they will give you symptomatic anemia if they're severe enough. They give you jaundice, and raised bilirubin will give you bilirubin gallstones with associated complications from the gallbladder. There are some crises seen, especially aplastic crisis, which is from parvovirus infecting the stem cells, and body is not able to compensate for the transient drop in cells and in the red cell precursor. That thus gives you very marked anemia. They can have splenomegaly. Pulmonary hypertension is very important to consider and rule out, because that can long-term hemolysis causes pulmonary hypertension. That's poor prognosis for any hemolytic related condition. There can be a risk of iron overload because of the disease itself, because the body absorbs more iron, or from transfusion, and along with the complications that happen from iron overload. And some of them can weaken the bones as well. Most important thing is blood film. This is where all of your part 2 is going to be tested for red cells. So this is because they are actually very important to the blood film will be the first thing to help you diagnose and guide you the right direction. This is a complicated diagram taken from Wikipedia, but I will try to simplify that, because this is actually not supposed to be that horrific, how the red cell membrane looks like. So you are supposed to have a red cell membrane, which is lipid bilayer. And then there is a cytoskeleton, which is somewhere here. So this is made up of phospholipids. You can imagine this is the phospholipid bilayer, with a bit of imagination, because my drawing with the mouse is not the best. But anyhow, so this is the cell membrane, and it's supposed to have these phospholipids, but of course it's supposed to have ion channels and other proteins that are doing their job and stuff like that. So all of this is held to the substance of the cell, which is a cytosolic substance of the cell with some proteins. So these are actin. They are present underneath the cell, and they're joined together here. So these are spectrin. So these wavy ones are spectrin proteins. They're held together by, sorry, somebody's now on mute. That's nice music, but I'm just going to mute you for now. That's okay. Okay, so, and they're held together by actin. So what happens is that red cell membrane is supposed to be anchored to the cytoplasm through this. So this is the cytoskeleton, and the way to anchor them is by another set of proteins, which are very nicely called anchoring proteins. So the anchoring protein, so this is an anchoring which anchor the spectrin proteins to the cell membrane, but there are some other proteins in between. So this is a protein, and then this is a protein that spans the width of the cell membrane. Oop, that's not good. Okay, so important names here. this protein on the outside is called band 3. This protein is called rather boringly 4.2. So this is actually how they were diagnosed on electrophoresis, the red cell proteins. So that's how they were named. But anyhow, what you need to remember, they are cytoskeleton, which is spectrin. It's going to be anchored to the cell membrane with anchorin, which also uses some help from protein called 4.2. And band 3 is important to know because it actually spans the cell, the phospholipid bilayer. Okay. And of course, there are other methods as well, where other proteins as well, which are going to help, link spectrin to there. But these are more important for our talk. Now, these are called the vertical connections. These 3 are vertical connections. And this spectrin actin is called the horizontal connection. So the red cell, if you remember, is something like a biconcave disc, right? It's because biconcave because the surface, the volume is low, but the surface, but the cell membrane is in excess. So cell membrane is a cell has got more membrane than its volume inside, and the reason is that using this, it can actually squeeze through narrow capillaries quite easily. Though, so a red cell is around about 7 microns, and some of the capillaries are like 2-3 microns. So if you want to pass this through this, then they have to squeeze through. So what they do is, because they've got excess membrane, they squeeze on themselves or squeeze through through these capillaries in the spleen, to be able to pass through them. So that's why they've got excess membranes. But the membrane, while doing so, while squeezing through the capillaries, if the membrane is not anchored to the thing, to the cytoskeleton, then as it's passing through, or normally, part of the membrane is going to be left behind because it's not strongly linked to the spectrin. So if these things are absent, then while the cell is passing through narrow capillaries or otherwise, this part of the membrane is not going to be anchored firmly to the spectrin, and it's just going to bud off and disappear. If this keeps happening over and over again, this cell is going to lose cell membrane. And if cell loses cell membrane constantly, it's going to acquire a spheroidal shape. This is because now it's got more volume and less membrane, and for a given volume and a membrane, if you've got less membrane, sphere is the shape that keeps the cell as such. So what happens in hereditary spherocytosis is you lose these connections, the vertical connections, and this part of the membrane is going to become all floppy. And when the cell is going through capillaries or otherwise, this part of the cell membrane is going to keep budding off, and the cell is going to change from the discoid biconcave shape to a spheroid because it's now lost a lot of its cell membrane, and it's going to just acquire become smaller and spherical. We see the same process, by the way, what happens in autoimmune hemolysis. So in autoimmune hemolysis, actually, these things are okay, but because they are coated by antibodies, when they're going through the spleen, macrophages are going to engulf part of the membrane that's bound to antibodies, and the rest of the cells managing to escape. So they're going to sequentially lose their cell membranes and progressively become spherical. So that's how spherocytosis happens. So problems with these vertical associations gives you spherocytosis. Problems with these horizontal associations gives you elliptocytosis, because cells are now going to acquire elliptoid shape. So I hope that makes somewhat of sense, because, and then proteins that you have
Sorry,
to
can you
remember.
come again with the last 2 sentences, please?
Which ones?
You said problem with this gives this and problem with that gives that. I didn't
So
catch.
vertical associations are going to be the problem in hereditary spherocytosis, because with vertical associations, you are going to progressively lose part of your cell membrane, because this is not going to be anchored to the anchorin and thus to the cell itself, the body of the cell. And then if you keep losing cell membrane, then if the cell loses the excess membrane that it has got, ultimately it's going to become spheroidal. And those spheroidal cells can't pass through narrow capillaries now, because they have got no flexibility on themselves now. They are going to go there and get stuck there, because they're still going to be bigger than 2 microns, and they're going to be stuck there. And the macrophages will see these stuck cells in these sinusoids in the spleen, and they're going to just engulf them and cause premature destruction, which is hemolysis. But if the problem is in these ones, similar problem, red cells, instead of becoming spheroidal, they are going to become elliptoid. That's just how they are, because then they can't maintain a discoid shape. They're just going to become elliptical because of how these are aligned, if you know what I mean. So normal. So this of course spans the entire cell. This structure, entire circular cell. So if these things are abnormal, the horizontal ones, then this is going to give you hereditary elliptocytosis. But if these are abnormal, it's going to give HS. Does that make somewhat of a sense?
Yeah. Thank you.
Okay, good. So I'm going to save this. Okay, and then get rid of this. How do we get rid of this? Okay. Oh, I hope you took a snapshot or something, because protein, I've got it. Don't worry, I'm recording this time. But I've got, the protein band 3 is important, which I will come to in a second. So hereditary spherocytosis, those vertical associations are the problem. Hereditary elliptocytosis and hereditary pyropoikilocytosis, horizontal association defect, is the problem. I will explain them in a bit, but this is just like a summary, so don't worry. So hereditary spherocytosis, cells become spherocytes and small, and then get stuck in the spleen, and the spleen just phagocytoses them. If it's just elliptocytosis, then they still retain some of their flexibility because they don't lose the cell membrane quite a bit. So they can still pass through the narrow capillaries, and that's why the hemolysis is mild. But HPP, which is hereditary pyropoikilocytosis, there's much severe hemolysis, and the shapes are quite bizarre. And this happens when you acquire genes that in a compound heterozygote or homozygote state for HE. So HE genes, which are the horizontal protein genes, but instead of just having one copy, so say you acquire both abnormal copies, and then the cells will have really weird shapes and sizes, and they will not be stable, and they will give you severe hemolysis in quite a young age. But HE is autosomal dominant, so one gene would be normal, so at least you have some protein that's there that can do its job. I'll explain them in a bit more. So as you remember, so red cell has got proteins in the cell membrane, carbohydrates or whatever, but also it's got ion channels. If the problem with the ion channel, you get something called stomatocytosis. So stomatocyte is a fish mouth red cell. So I'm not going to draw that for here. Oh, sorry. Where is it gone? So if you see the cells, they will have like a stoma. But anemia is variable. The important point is in stomatocytosis, you do not rupture this, or you not rupture, sorry. You definitely don't rupture the spleen in anyone, but you do not take the spleen out in hereditary stomatocytosis, because the problem is not the spleen removing them. Problem is just the red blood cell not being functioning properly because of the ion channel problem. So the electrolytes are not going to be kept nicely in and out of the cells. The balance is disturbed, and that's why they swell up or they become very dehydrated and die in the vessel, not necessarily in the spleen. And this is an important exam point. They'll give you hereditary stomatocytosis, make it sound like a bit like hereditary spherocytosis, and they'll say, do you want to take the spleen out? And you'll say no. And I will test on similar lines in the practice session. So there you go. There's a question already out. And then there's another thing called Southeast Asian ovelocytosis, which is a benign problem and problem with protein 3. Film in this one will show ovelocytes and stomatocytes. Hereditary spherocytosis will show you spherocytes. No surprise there. Elliptocytosis in the mild form, hereditary elliptocytosis will just show elliptocytes. HPP will show you bizarre cells of various shapes and sizes, which you cannot definitely say this is this shape or that shape. They may show you some elliptocytes as well, but there will be all sorts of shapes. Stomatocytosis will show you stomatocytes. Ovelocytosis will show you ovelocytes plus stomatocytes. That's how you remember them from the blood film. So that was in brief. I'll go to in a bit more detail in hereditary spherocytosis because there's a guideline on that. So if there's a guideline, you can be tested. And this is actually the most common of them. So you need to know as well. So it can present at any age, variable severity. Diagnosis, how you diagnose. If there's a family history, so mom or dad has it, it's autosomal dominant. So, and you have typical clinical pictures of hemolysis that I mentioned earlier, and lab features like spherocytosis, reticulocytosis, DAT negativity, because spherocytes can be seen in autoimmune hemolysis. or you have high MCHC, so mean corpuscular hemoglobin concentration. So as you imagine, so spherocytes have lost their cell membrane, it's gone. So now they've got less cell membrane. Previously they were quite baggy, so to say, and they've got good space in them to carry hemoglobin, but now they've got less space. So the concentration of hemoglobin per cell is higher. That's why you see high MCHC. Then you don't need to do any further testing. So this is diagnosis done. But if in atypical patients, you can do some other tests, which are like EMA binding or cryohemolysis. Plus minus, you test the family for these things, or plus minus this, and see if one of the family members might have it, but it was asymptomatic, for example. Gold standard apparently is gel electrophoresis analysis of the red cell membranes. So you lyse the red cell membranes proteins, and then you run them on an electrophoresis gel and see if they are deficient in those proteins, which we know they are deficient in hereditary spherocytosis, which are those vertical interaction proteins. And you have to do that especially prior to splenectomy, because you definitely want to confirm that. But this was based on the old guideline. But of course, nowadays we would like to do genetics as well to confirm if you are embarking on a thing like splenectomy, or in severe cases where you expect that this is actually more severe for what we see at chest. So you want to be really sure before you embark on a big thing like splenectomy that this is the diagnosis. Now, so that's how you diagnose it. I'll briefly mention two tests that they can ask in exams. In the guideline, they say EMA binding is good, is a good screening method. So I'll just mention that. Actually, osmotic fragility is how it was used in the past to screen for it. It's gone out of fashion for real life, but not for exam. So hereditary spherocytosis, red blood cells are more fragile in hypotonic solutions. So if there's a hypotonic solution, then the cell, the water is going to. So if you leave these spherocytes in a tube with a hypotonic solution, the water is going to try to go into the cells. But as you say, there's not enough room now because they're smaller and packed. They're going to burst and lyse. So you will say they are too fragile compared to normal cells, which maybe they will lyse in a bit longer. Spherocytes will lyse earlier. But the test that's done, and you definitely need to know, is EMA binding test. It's a very fancy name, but basically what EMA does is EMA dye, it binds to the band protein 3, which I mentioned, if you remember, the band protein 3. It binds to that. So, and then you do a flow cytometry, basically, after exposing them to this dye. So HS cells would have low band 3. The proteins that I showed you, the vertical associations, any of them, if it's deficient, then it's most likely going to lead to the fact that the band 3 protein is not going to be either the band 3 protein is going to be absent because of genetic test, or if other proteins are absent, then because band 3 is not anchored properly to the cytoskeleton, it's going to be lost. So band 3 protein is going to be in low numbers on the cell surface in that cell, HS. So if you expose that to the dye is supposed to bind the protein. But if there's not there, it would show low fluorescence, and this will show reduced band expression. I'll share a graph. I forgot to include it here, but I'll share it on the group, how it actually looks like on paper, and they can easily give you that in MCQ and say, what does it show, and what's the diagnosis. So they will have, HS red blood cells would have low fluorescence because it's low band 3, normal would have more. That's all. How do you treat it? Mainly supportive. Most people are okay with that. Just a bit of folic acid and counseling for aplastic crisis, especially in the youth. Folic acid is required for lifelong required. Splenectomy can be done partial or full, but in severe cases, as I've summarized the criteria here, but it's a very nice table in the VSH guideline that you can go to. Laparoscopic is preferred. If there's also, you take a gallbladder out at the same time. You at least wait for 5 years or more, or at least 6 years to do splenectomy because of more harmful consequences before that. But what you have to do before splenectomy is, number one, make sure this is HS and rule out other causes which may look like may be similar to HS, but splenectomy doesn't benefit them. So hereditary spherocytosis or CDA, which we will cover. And the way to do that is specialist testing or genetic testing. The problem with genetic testing is still takes a bit longer to come back. You can push them for some urgent results, but still it takes a few weeks to come back. So if you're in a rush, you might need to do the other testing. And post-splenectomy care, you have definitely mentioned antibiotics immunization and give them a card for these carry marks in the exam. Of course, if this is a baby, a neonate that's been diagnosed with severe HS, they will present with neonatal jaundice, and you will manage them as you manage neonatal jaundice, phototherapy, exchange transfusion, etc. And you would differentiate them from HDFN by doing a DAT. So in HS, the DAT screen is supposed to be negative. Okay, in HDFN, hemolytic disease of fetus and newborn, which is prostate activity, immune mechanism, so that would be positive. This is a summary slide that you can go through afterwards. So HS we have covered. Erythrocytosis, as I said, is horizontal proteins, but mild anemia and stuff. HPP, two or more defects of erythrocyte, two defects of erythrocytosis, so severe anemia, and in infancy, transfusion dependent. Blood sphere is horrible. Genetic testing can be used, and transfusions, sometimes splenectomy. Stomatocytosis has got two types, dehydrated or overhydrated. So remember, it's an ion channel problem. So either it can lead to dehydrated red cells or overhydrated red cells. And it will show you stomatocytes on the film. You avoid splenectomy in all of them. So this is the main disease, and these are the two subtypes. Southeast Asian ovalocytosis just gives you resistant to malaria. It's an asymptomatic condition. You don't need to do anything. And this is just for fun. At the bottom, there's another thing. If this enzyme is deficient, it's called haemolysis as well. Hopefully they don't know. But the good thing is that genetics are supposed to test, when you do a genetic panel, you're supposed to test to keep all of these tests in there. Quickly going to the enzyme problem. So there are three more important enzymes, most important being T6PD. Pyruvate kinase is the other one, and nucleotide problem. So in exam, they're likely to ask you about the first two. G6PD, as you know, is required to keep a store of NADPH, which is required to fight oxidants. If they are not there, oxidant-related damage will cause hemolysis of the red cells because it's going to denature red blood cell, hemoglobin, and membrane, because intravascular hemolysis plus minus in the spleen. Usually you get acute intermittent hemolysis after oxidant stress, but neonatal jaundice can be seen. Of course, neonatal jaundice can be seen in early period, and it's not necessarily from hemolysis, but the G6PD is just lacking in liver cells as well. That's probably why. There is a rare variant where you get constant hemolysis instead of acute hemolysis, which is congenital non-spherocytic. Is an important cause of congenital non-spherocytic hemolytic anemia. You see in these ethnicities, as you know, the four types, depending on how much the activity is. More than 60 is normal. Less than 10, either they can have congenital constant hemolysis, or they can still have severe episodic hemolysis. Depends on some of the kinetics of the enzyme. Most common is African A- variant, which is only affects the older red cells. So hemolysis is mild even when it's from stresses. This is how the blood film looks like, and this is the hemoglobin trying to denature and go towards the periphery, and this is ultimately going to be bitten off, so become a bite cell when it goes to the spleen. So if you see bite cells, so diagnosis again, the most important thing to diagnose is blood film. You see blister cells and bite cells. You can see Heinz bodies, which you have to do a special stain for that. Oh, yeah. 1 second. The other thing to do is G6PD level, of course, but you don't do it during hemolysis because reticulocyte counts have high reticulocytes, and they love to check that in exam. So you wait for the testing to be done till the hemolysis settles. There are two methods, qualitative or quantitative. In males, you start with the qualitative, and if it's positive, you go on to quantitative, because this is X-linked recessive, remember. So males are likely going to have, if they're deficient, they're likely going to be quite deficient in it. So screening test is going to pick up. And then if it is positive, then you do a quantitative assay. In females, you move directly to quantitative. So even though it's X-linked recessive, but it can be seen in females as well because of various problems, as you know, with X-linked recessive diseases coming in females. Reticulocytes have higher concentration, so you have to do it once the hemolysis settles. Anemia and leukocytosis can interfere with the screen results. So anemia is going to falsely give you low levels. Leukocytosis is going to give you falsely high levels, because leukocytes also have G6PD, no surprise. If there's a recent red cell transfusion, you can't test it, of course. So there's, of course, genetic testing can be done as part of the R92 panel. PK deficiency, so G6PD, X-linked recessive, usually intermittent hemolysis after an oxidant stress like antibiotics, fava beans, antimalarials. Respiricase is what they're going to probably ask you in our exam. So respiricase is an antioxidant drug. And treatment is usually supportive. Don't give them those oxidant stuff. And if it's chronic hemolysis, you transfuse. Diagnosis is with a qualitative test and a quantitative test. In males, you start with a qualitative test. If shows that, fine, you go into quantitative. In women, you jump directly to quantitative because the levels can be at a level that might give you falsely negative qualitative test. You have to wait for the hemolysis episode to settle, and you can't do that if there are recent hemolysis test for D6PD cells. Genetic testing can be done, of course. PK deficiency, on the contrary, is an autosomal recessive. It's in the PK gene. This is an exam question, so it's increased incidence seen in Amish population because of consanguinity, etc., and affects glycolysis pathway. So PK deficiency is going to lead to low ATP, rigid cells hemolysis. But they also produce high 2,3-DPG, which, if you remember, if there's high levels, you shift the oxygen dissociation curve to the right, and then oxygen is easily available to cells, even though the hemoglobin is lower. And symptoms are actually less severe than the hemoglobin suggests. So hemoglobin might be in 60s, but they might not be as symptomatic. So chronic anemia is there because it's a constant enzyme deficiency. You don't need triggers for that. But if you have infections and stuff, it's going to get worse because it's going to make the effect of deficiency worse. You can have skeletal changes because of ineffective erythropoiesis, body trying to compensate. Iron overload can be there. This is the only place where blood film can be very less helpful because there's no specific features, but that's actually a good test in itself. Sometimes people see something called prickle cells, which are acanthocytes. So acanthocytes are red cells which have got horns coming out of them at irregular intervals. Echinocytes have got horns coming out of them at regular intervals. Acanthocytes are the ones that have got horns coming out at irregular intervals. And some of the specific ones look quite prickly, so prickle cells, but they're not very specific. You test them by enzyme assay plus by genetic sequencing. They will ask, this might come in the exam, because now we've got a treatment for that, which is mitapivat, which is an oral PK activator. So whatever PK is there is going to force it to do its job better. And it works quite well in short-term studies. It's very safe to use so as well. Splenectomy may help, but doesn't may reduce anemia, but it doesn't cure it. So HS, if you do splenectomy, it actually normalizes your hemoglobin. So that's why if you do splenectomy, hemoglobin doesn't normalize, you say, oops, in HS. But in PK, it may reduce anemia, but doesn't cure. This is sometimes they like to test. So if you do splenectomy, even though the hemolysis has improved, but you see a very, very high reticulocyte count, which you've probably never seen before, 40 to 70% of the red cells can be reticulocytes. This is because they were previously being stuck in the spleen, specifically in this condition. So when you remove the spleen, all of them can happily float around now. So you'll see a massive reticulocytosis, but the hemolysis is not that bad. And you give iron chelation, and gene therapy trials are ongoing for severe cases. This is a summary slide which you can go through, but you have to focus on D6PD and pyruvate kinase deficiency. The last one that I mentioned, pyrimidine 5-nucleotide, you will see in the exam anemia, hemolytic anemia, but basophilic stippling will be there, and some neuro features. So you can think of this deficiency. If they give you a G6PD like picture, but like oxidant drug has been given, hemolysis is there, but G6PD has been done after hemolysis and the levels are normal, then this could be one of these. So glutathione problems, so which is actually another, this is the thing in the pathway. If the levels of enzyme are normal, but the substrate is not there, that will give you similar problems. So if the G6PD levels are normal, you suspect there's a glutathione problem. And that's it. And if you see hemolysis and neuromuscular myopathy problems and just vaguely remember these names, this might be the answer. So in myopathy, neuromuscular problems and hemolysis, so I'm not even going to pronounce them, but this is what you should have it at the back of your mind. But what you should focus on is G6PD and PK mainly. Okay. Not long left, but this is my aim with this. Is only a few more slides left, but my aim with this was to cover DBA, CDA, and sideroblastic anemia, and basically give you like a mind picture of, if you read these names, something comes in your mind, like tries to give you a picture of how they look like, because that's the most important thing, and that will help you in MCQs and real life as well. So there are three problems that I'm going to discuss. So remember from the first slide, erythroid progenitor failure. So it can be DBA, CDA, or sideroblastic anemia. So these are where the progenitors are the problem, but specifically the erythroid ones only. So you're not seeing pancytopenia, but you're just seeing anemia. DBA is a congenital red cell aplasia. So the red cell precursors are like diamonds in them because they're very rare to find. So this is just congenital red cell aplasia. What you will see is anemia, which can be macrocytic, but you will see reticulocytopenia because there are no red cells. So it's basically red cell aplasia, that's why. And in the bone marrow, you will not see any erythroid precursors or see very little. So that's the diagnosis there. And then you can do genetics. So Diamond-Blackfan anemia is basically pure red cell aplasia congenitally. CDA is, I don't want to say this is MDS, but this is something similar. So ineffective erythropoiesis, which is congenital. Ineffective erythropoiesis means that there are lots of precursors in the bone marrow which are trying to multiply and differentiate and become mature cells, but by the time they reach the final stages, they just all die before becoming red cells. So the bone marrow will be packed with erythroid cells, which are trying to differentiate and blah, 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 and trying to divide and actually differentiate into red cells, but they actually never do so. The bone marrow will show lots of red cell precursors, but the blood wouldn't show any red cells or less red cells. That's why the anemia. And you will see a very abnormal film in here because they're dyserythropoeitic. So this is, as I say, MDS-like, but the red cells will be very weird shapes and sizes. So if you see a blood film with weird shapes and sizes, differential diagnosis is hereditary pyropoikilocytosis or CDA. And there's nothing characteristic from them in the blood film, but they just look very weird. If you Google them, you will see what I'm saying. And in the bone marrow, no surprise, you will see this erythropoiesis, and the spellings are not right here, but there are specific changes that you will see. So multinucleate or binucleate or trinucleate red cell precursors. So this is what it should show. Sideroblastic anemia is simpler. If you just see anemia and pathological ring sideroblasts in the bone marrow, then this is what sideroblastic anemia is. So DBA is congenital red cell aplasia. CDA is ineffective erythropoiesis, as the name suggests. So you don't need a mnemonic for that. So you'll see abnormal film in there and dyserythropoiesis in the bone marrow, as opposed to relatively benign-looking film in peripheral blood film DBA, but bone marrow won't show any precursors. Here they will show lots of precursors, but they will be very horrible-looking, not normal. And then sideroblastic anemia, you will see ringed sideroblasts, which are a specific type of, basically you will see red cell precursor, which I'll show you a picture of, nucleus is surrounded by iron deposits, because the problem is that the iron is not being incorporated into heme for various reasons, even though it's present there. They can ask you definitely about the pathogenesis of this. So, of course, this is a acquired syndrome, so they will have congenital anomalies as well. And what you have to remember from this slide is that ribosome biogenesis is the problem. So ribosomes are not being formed properly, not doing their job. It leads to increased TP53 activation and cells die. That's why there are no cells. And gene RPS19 is what you have to remember. Very easy to ask in exam. But there are other ribosomal proteins that can be abnormal. Ribosomal problems are also seen in some other problems. MDS with 5q deletion, if you remember, is a specific MDS type, and Schwackman-Diamond syndrome, which is a cause of inherited bone marrow failure syndrome. Anyhow, that was just for fun. Cancer risk. So they have a high cancer risk, even the carriers, and not just heme cancers, but non-heme cancers as well. So DBA, you have to, we have to monitor them for that as well. I've explained all of them already, the reticulocytopenia and anemia, but characteristically, HPF can be seen. So any time bone marrow is stressed, it tries to produce lots of different types of hemoglobin. And one of them is, of course, it tries to do anything it can to help. and our body can produce hemoglobin F, but if it's stressed, it might produce it in a bit more quantity. That's why the hemoglobin F can go up. But what's very specific is, or actually specific for exam, is EDA. So ADA, sorry, ADA is an enzyme which is going to be increased in DBA. So that's how you remember ADA, DBA. And this is just our coping mechanism. It's a marker of stress erythropoiesis. I can explain you the mechanism, but it just will bore you. Bone marrow is not going to show you any precursors there because this is pure red cell aplasia. And the other, of course, R92 panel is going to cover that. It's important to diagnose them. They're present in early infancy. And the first line treatment is transfusions and corticosteroids. But you start steroids only after a year of age, or at least consider though, because before that, the risks are quite high. And there's a good response, as you can see. That's why it's important to diagnose and treat accurately, because many of them might not have any treatment. The remission sometimes can occur spontaneously, but if they're steroid refractory, the next line is transplant. So if they're steroid refractory, still requiring transfusion, you do allogenic transplant. And as with anyone, you do inoculation. But important exam point and real life is you avoid deferiprone. If you remember, there are 3 drugs for inoculation. Deferiprone is one of them, and it's got a risk factor that it causes agranulocytosis. You do not want to risk that here in Diamond-Blackfan anemia because they're more susceptible to that. So you don't give the neutropenia as well as the already existing anemia. So you don't use deferiprone, and you surveil for other cancers, which is very important. The DBA, this is also pure red cell aplasia, response to steroids, and you don't use deferiprone, and surveil for other cancers. PDA, ineffective erythropoiesis, bone marrow going to show multinucleated cells or internuclear bridges actually as well. In exam, they will say, oh, this shows Swiss cheese nuclear chromatin on electron microscope. This just shows dyserythropoiesis. So it shows Swiss cheese that this is CDA. And there are lots of mutations. You can try to remember, but just vaguely have them in your mind. But of course, you cannot remember them. So there's no need to remember them either. But they will be covered in the R92 panel anyway. Peripheral blood looks very abnormal. Bone marrow looks very abnormal. And treatment is supportive and inoculation. But in some CDA patients, you can use interferon. And this was actually incidentally found out that interferon works in them. And the only treatment curative is transplant. So that's why steroids don't work in CDA. So as I say, CDA, you think of like an MDS like of picture, congenital. So steroids don't work. For some reason, interferon works. We don't know why, but transplant is the only other option. Sideroblastic anemia is defined by sideroblast in the bone marrow, which is, I'll show you the picture here. And again, so the red cells are there, erythroid precursors are there, but they cannot incorporate iron into hemoglobin. It's just stuck at the boundaries of the cells or whatever, and they cannot incorporate that into heme. And that's why they try to work harder, but ends up with ineffective erythropoiesis, which means the same thing. So bone marrow stem cells are populating, but they are not actually translating into mature cells. You see erythroid hyperplasia as well. Findings are in the hereditary forms, you will see microcytic hypochromic anemia because there is iron problem. So iron is not being incorporated, there's less hemoglobin. That's why hypochromia and microcytosis. But sometimes you see dimorphic films. So if the defect is mild, some cells can incorporate iron there, so they will be normocytic, normochromic. Others might not be able to incorporate, so they will be hypochromic, microcytic. And bone marrow is going to show you lots of ringed sideroblasts, and this is what sideroblast looks like. So this is a red cell precursor, and these are so many iron deposits which are being stained with an iron stain, Prussian blue stain. Normally, you're supposed to see just 1 or 2 in the cell, but this, as you can see, they're making a heavy ring in there. So if you see more than 15% of them, or you see a mutation in MDS, so that's sideroblastic anemia. And it can be hereditary or acquired. Hereditary, this is what they will ask you in exam. X-linked ALAS gene, alanine synthase, and this will respond to pyridoxine because it's one of the enzymes in the same pathway that uses this. So they can be non-syndromic or syndromic. And the other thing is same X-linked with ataxia. So X-linked ALAS gene, which is XLSA or XLSA with ataxia. Other you don't need to know, but they may ask you MCQs, but you don't need to focus too much about. So if there is sideroblastic anemia and pancreatitis, then this is Pearson's disease syndrome. And there's a thing called thymine problem, thymine transporter gene mutation. So they can't use thymine properly. So thymine, if you give thymine, then that will help. So again, they will have sideroblastic anemia and megaloblastic angios, but thymine is going to correct the anemia. The sideroblastic anemia can be hereditary or acquired. Hereditary, what you don't know about because probably you've never seen, I've never seen. It's X-linked ALAS gene mutation and response to pyridoxine. Acquired is, sideroblasts can be seen from lots of other problems. So clonal like MDS, as you know, withering sideroblasts with this mutation, but the other non-clonal causes like alcohol, drugs, especially isoniazid can cause it. So of course, seeing sideroblasts doesn't automatically mean hereditary sideroblastic anemia. Treatment, I've just mentioned targeted treatment here because this is what is relevant for exams. So pyridoxine is useful in ALAS mutations. That's going to be the answer. So it will be a young male with anemia, may give you dimorphic blood picture, and bone marrow shows ring sideroblasts. What's the treatment? Pyridoxine, you can try and see how it goes. In some other problems, which I mentioned, thymine transporter problems, of course, this will be diagnosed on a genetic test as well. You can give thymine plus supportive management or transplant or whatever if it's severe. This is a summary for all of that I've said. DBA is pure red cell aplasia, red cell precursor's like diamonds. You can't see them in there. And EDA, so ADA is raised in DBA and response to steroids. CDA is like MDS for congenital MDS. And so blood film would not be right and the bone marrow won't be right. Mutations are in some CDA genes, various different names. Sometimes interferon works in type 1. Sideroblastic anemia, usually child or young adult, male, but can happen in females because this is again X-linked mainly, but again similar thingy with X-linked, any X-linked recessive disease can occur in females as well. They will give you a young male, ring sideroblast on the bone marrow, maybe dimorphic picture on the film, and iron levels are normal or actually raised. Iron levels would be raised because of iron overload. And this is what the bone marrow is going to show. So ring sideroblasts, and you treat it with, if it's in acquired form, you treat it with pyridoxine in the exam and other things like transfusion stuff. Lastly, I've incorporated the things from the NGS guideline in throughout the talk, but it's very important. The summary of the guideline is very important to consider. NGS now is getting more and more done earlier in the pathway. It's because 40% of cases there's actually a misdiagnosis. You've been treating for something else and actually comes out to be something else. Because let's be honest, these hereditary anemias, all of them present with anemias, and they're having so many complications like transfusions and this and that, and bone marrow might not be typical, blood film might not be typical. All the tests have got so many issues like HbF can be high and other things, problems doing the tests properly, the requirements to do the test, etc. So a relatively simpler way is to do NGS, but it's not to say that this is always going to give you the answer, because it might just give you variant of unknown significance or whatever. But this definitely helps in clear-cut pathogenic variants being identified. You definitely do this if you are planning big things like splenectomy and BMT. And if you're using panels, you have to ensure that the panel covers the most up-to-date list of genes, because genes continue to get being discovered, and most of these NGS panels are targeted gene panels. So they may do 20, 30, 40 genes. So there's like an anemia panel, which is R92. So they will cover all the common inherited anemia genes. But you have to ensure that it's up to date, which likely the NHS would do if it's available on NHS, etc. But this is what you have to ensure. Exactly where it sits in the pathway is individualized at the moment. So it's not like everybody should have NGS, but of course, in tricky cases, you should do NGS. So I remember there was a patient who was diagnosed with anemia. And in the childhood, they were given steroids and the anemia responded. But then slowly now they're an adult now, and they're quite short stature and things. And they were not responding to steroids anymore. They had reticulocytopenia. But in the childhood, they responded to steroids. and they're just being monitored because the hemoglobin has been stable, so nobody did anything, but they're just being monitored. But now they're starting to become anemic again, and they're in their mid-20s and stuff. And I was sat there as an ST3 listening to a talk about CTA and DBA from an expert in Oxford. And I rushed to the one of the colleagues to say, "Oh, this could be DBA, it fits, etc." And he said, he was another colleague as well. He said, "Yeah, we've just been monitoring her." He was also not a consultant. He said, "Yeah, I'm monitoring her, but I was actually in the same talk as well, so I've sent an NGS, so don't worry." Good. And they actually turned out to be having DBA. So at least we have the diagnosis. We referred. This was in a DGH, and we referred them to a tertiary hospital, but apparently they've got clinics full of that, which I know now because I've been to that tertiary care as well. That's why NGS is important. And I've used lots of resources which you can go through if you want, but this presentation is hopefully going to be enough that you need for the exam. That's all.
Thank you for watching. Stay tuned for more.